Thank you very much, and let me say first of all what an honour it is for me to be invited and be given the opportunity to come here and speak with you. So we've got 6 lectures, and I realise some of you can be in some and out at others. That's absolutely fine, and we are being recorded, so I doubt if it'll go viral, but I'll try and be honest and frank, but not rude about anybody. I'll try and manage that. Right, I would like it to be as interactive as we can, so because we're not a huge group, I think it's entirely all right to have questions or comments, or if at some point you just say it again, repeat it, or tell me it again another way. Please do, please do. Right, let's just go back to starting point. Health economics and social capital. This picture, I don't know if it's clear enough. I was attending a health economics conference in Spain. Pamplona, I think it was in. And this was a student artwork or exhibit that was in the building where the conference was being held. And so you can see what the student thought about their studies. This chair is a bed, is nails. This is a literal bed of nails. Reading is like having nails put in your eye, and you can't even put your elbow on the table and relax. There's nails there as well. Now I put that up because this course is going to be the opposite of that. It's not going to be hard, nails, uncomfortable. We want it to be quite the opposite. And I don't want you to have any association in your mind between health economics and pain or discomfort. I mean, yes, we're interested in sickness and health, so there is pain there, but not during the class, please. Right, just an overview of what we're going to look at. The first lecture, imminent, this morning, what is health economics? Now, I know some of you will know what health economics is, some of you will think you know what health economics is, and some of you will be wondering, what is it? Why did my professor encourage me to come along to this, if they did? And so that'll be the first thing. Just try and give you a flavour of what's involved in health economics. In the first lecture this afternoon, I'm going to move on to social capital and look at some of the issues involved in measuring social capital. And it's really difficult. Not difficult in the sense that mathematically difficult or technically difficult. It's just difficult, first of all, to arrange and organise the different concepts of social capital. And then having decided what the concepts are, it's really quite challenging to decide what might be a good measure or good measures of social capital. And we'll look at that this afternoon. Then on Monday, 11 o'clock I think, I'm going to look at specifically social capital in the context of health economics. What have health economists contributed or tried to contribute to the study of social capital? I think it's fair to say that health economists came along quite late to social capital. It's only about the last 10 years or so, slightly longer, that health economists have been very interested in social capital. But health economists think they have something distinctive to contribute, and I'll try and convey to you the contribution or potential contribution of health economics. Then Monday, I guess 1 o'clock, is that right? Yeah. I'm going to think about the implications for health policy and for research. Implications arising from the potential role of social capital, and trying to understand the role of social capital, what implications it might have for health policy. And then on Wednesday, 11 o'clock, I'm going to talk more broadly about the role of economics in priority setting. priority setting in a health context. So what are the sorts of decisions that health economics and an economic approach might help us with? And then the final lecture is going to look at a particular problem, and it's a problem in every country in the world. It's certainly a problem in England, but I'm sure it's a problem, I know it's a problem in Japan. It may not get a lot of attention, and it's the issue of high-cost medicines. New medicines are, by and large, wonderful things. Frequently, they are bringing potential benefit to patients who have serious problems, sometimes problems that we've been unable to deal with in the past. So they're good. Unfortunately, they frequently are very costly. And what that implies is if we're going to spend on these new medicines, we're going to have to take the money from somewhere else. Now, it doesn't matter where we take it from, there is going to be sacrifice. You could take it from another part of the health service, and there'll be obvious loss of benefit to patients elsewhere in the health service. You could take it, as it were, from another part of the economy. You could move more resources into the health sector. But there's still a price to be paid, the sacrifice. You're losing the benefits of spending elsewhere in the economy. And so in the final lecture, I want to look at some specific examples of this challenge, and there's two areas I'm going to look at. One is treatments for HCV, or hepatitis C virus, HCV, and it's a particular issue in Japan because you have a relatively high prevalence of HCV. And the other one I'm going to look at is in the context of new cancer therapies. And particularly, I'll look at non-small cell lung cancer. But it doesn't really matter which cancer area we take. Thankfully, there's lots of new treatments coming along, but they just all have a very high price tag and give us this real problem, this challenge, that how are we going to be able to afford them? In what circumstances perhaps should we say no? And that's a tough decision, but the argument is that health economics can help you with that decision. It doesn't take it for you, but it can help you organize your thinking. It can help you interpret evidence that's relevant to your decision. So that's what we're going to cover, and I hope there's a bit something in there for everybody. I realize that some of you might be more interested in social capital aspects, some of you might be more interested in economic evaluation or cost effectiveness aspects, but that's what we're covering. Now, is there something somebody would love me to cover that I'm not planning to cover? Or you can tell me at the end, once we get to the end of the 6 lectures, you can say, well, that's fine, thank you, Professor, but why didn't you talk about, and well, we'll see, maybe come back again another time. Okay, so lecture 1, what is health economics? Oh, by the way, that's my email address. If you want to sort of communicate, well, do feel you can speak to the real person. You can do that, but sometimes people might have a query or a question or something that you don't want to look me in the eye, send me an email, or you might have something you want me to comment on or something, and I'd be happy to try and do that. Right, now this is all rather complicated looking, but it's not really. This is sometimes described as, after the author, Alan, so I can actually use this pointer, Alan Williams. It's often called Alan Williams' plumbing diagram because it looks a bit like a central heating system. If you can imagine, these are the radiators and these are the pipes connecting the radiators. So you can imagine a sort of central heating system. And so it gets referred to as this plumbing diagram. And it's an attempt to summarize all the different sorts of areas that make up the subject area of health economics. Alan Williams is a very interesting person. Whoops. It's a very interesting health economist. He's one of really the founding fathers of health economics, and indeed one of the relatively few health economists who's ever died. Now that's not because health economics gives you longevity. You know, health economics is good for survival. I don't think that's the case. It's a new subject area, and being a new subject area, a relatively new subject area, most of the people studying it, well, at one point were quite young, and so it's he had a full and very happy life, I should say, so there's not a cause for sadness, but he is one of the few health economists who's no longer with us. Right, let's work through this. Now, there's various points here that to highlight. First of all, if you ever studied economics at all, sort of Economics 101 or something like that, you probably were introduced to the concept of demand and concept of supply, and so what factors affect the demand for a good, what factors affect the supply of the good, and then their interaction together in the market. And the market generates signals which consumers respond to, signals which producers respond to. And so, indeed, in this context, we can imagine a demand for healthcare, a supply of healthcare, and the interaction would take place in some form of market. Now, we see a bit of that, but in most countries in the world, in fact, I would say in every country, the government is unwilling to leave all the decisions about healthcare, all the decisions what healthcare to provide, who's to get it, and that sort of thing, what technologies to use. The government's unwilling to leave it to the marketplace. Now in lecture 5, we'll go into some detail as to reasons why governments, and I mean all governments, I can't think of a single one that doesn't, to some extent, want to regulate the market. We sometimes think of the United States as being, United States of America as being a country where private healthcare is dominant and the market determines what happens. Well, even in the United States, I think it's 48% of the spending on healthcare is federal government money. So even in the sort of bastion of free enterprise that the United States is, even there, the government's playing a major role in the health economy. This question, yes?
It's not a question.
Or comment.
Is there any way that you can share that PowerPoint slides with us?
Ah, yes, I can. I can. We were just discussing this about 10 minutes ago. I wasn't too sure whether at this university you put things on a sort of site and students download, or whether you get hard copies distributed, and the suggestion was it was rather more common to get hard copies distributed, and so at lunchtime I will pass my memory stick over, and I'm not guaranteeing they'll all be immediately copied, but certainly we'll have, well, yes, I'm sure it'll happen quite quickly. So yes, sorry, thank you very much for pointing that out, yes, yes. Because of course, nice while it is to be filmed and recorded, I guess it'll be a little while before all that's available, and by then you'll have forgotten all about health economics. So yes, so it will happen. I just can't make a commitment as to how rapidly the printing will happen, but I'm sure it'll be quite quick. Okay, right, so the point there was, yes, as in traditional economics, in health economics, we do have demand for healthcare, we have supply, we have a market sometimes, but frequently the government replaces the market or introduces regulations on the market's behaviour. And one important area in health economics is to consider what determines demand. Now, obviously, many things affect our health, and healthcare is only one of them. Now, in a school of public health, we hardly need to emphasize that. Maybe in other areas of medicine, that's sometimes overlooked, the contribution that other factors make to the determination of health. And so that's one area of study in health economics. So for example, individuals engage in some behaviours which are very good for their health. It won't have transformed my health, but we walked up the stairs. We didn't take the elevator to come to this class. Well, if you do that routinely, you are, through that behaviour, one hopes, having a beneficial effect on your health. There's also things we do, or some of us do, that are rather bad for our health. Some of us drink too much alcohol. When I say some of us, I mean other people, not me. But some of us smoke and things like that. So there's lots of things we do that are actually bad as well. Well, those behaviours are susceptible to study with economic methods. Now, an interesting area of health economics is to ask the question, well, what is health and what is its value? Now, if we were some other part of the economy, suppose we were studying the computer industry, you wouldn't spend a lot of time thinking, so what's the value of this computer? I mean, you just wouldn't. But health is actually one of these areas where we do spend a lot of time thinking, well, first of all, what is it? And what is its value? And the reason for that is, if you are going to at all intervene in markets and in healthcare markets, you do have to start addressing these issues about what is the value of better health. Now, in the computer industry, it doesn't matter, because we're quite happy to leave it to all the individual consumers to make their individual decisions about whether they want to buy a HP. Sorry. This lecture is brought to you by HP. That's not a Japanese make. I'm surprised. Oh well. Now, in that sort of industry, the government doesn't worry about, oh, we're going to provide this type of computer only, not this one. But in healthcare, that does become an issue. And so the whole question of what is the value of health is an important topic. And because governments are frequently replacing the markets in terms of demand and supply of healthcare, you have an area of health economics looking at the evaluation of different health technologies. It might be new drugs, it might be imaging technologies, it could be anything to do with healthcare. And because we're not leaving it to the market to make these judgments, but we're trying to maybe some sort of committee is going to make, or ministry or whatever, is going to make a determination whether something should be provided or not, you then have to have an alternative mechanism for calculating the benefits, calculating the costs. And that's the sort of topic we'll be examining particularly in Lecture 6. Now, another whole area of health economics concerns the healthcare system as a whole. And again, it is a system. It's to some extent organised. And so there are issues of planning, budgeting, monitoring, what mechanisms to use. And that's another area that health economics tries to comment on. So those are the main areas. And as I say, we're going to start, well, this afternoon and Monday. I guess we're in this territory here. The idea is social capital may be a contributor to health behaviours, and therefore maybe the demand for healthcare, but it may also influence how people value healthcare. So that's the sort of territory we'll be in there. And as I say, on Wednesday, we're going to be more in this territory here. If you're replacing the market and how are you going to make decisions, and what sort of information, how can you combine the information to make judgments about specifically perhaps the cost effectiveness of different ways of providing healthcare. So in this short course, we're not going to try and cover everything. Those are the things we're going to cover. Okay, right. Some of you may have heard that economics has been referred to as the dismal science. It's the sort of epithet that's used again and again, the dismal science. And this quote comes from Alan Williams. He argues health economics is the cheerful face of the dismal science. Now, this description, dismal science, first of all, quite nice to have economics regarded as a science. I'm not sure it is, but let's focus on the dismal bit. This description actually comes from Thomas Carlyle, and it is widely believed that he was responding to the gloomy predictions of economics. The idea that, this is going back in time, that the population will always grow faster than the supply of food. And this seemed to be one of the messages back then coming from economics. And it was thought that's why he called it dismal, that it seemed to not be a very happy story. But in fact, if you look at the history of it, that's not where the dismal bit came from at all. It's an early form of propaganda. And it was an attack on economics from those people who didn't like the position economics was taking on slavery. And there were people who were against the emancipation of slaves, and they saw economics and economists as being against that system and trying to, as it were, free the slaves. Economics were preaching, and economists preaching principles of equality. And so I think if that's the reason it was called dismal, I think it's quite nice to be dismal if you're preaching equality. However, I can also see why people were very ready to accept that economics might be the dismal science, because economists are always emphasizing scarcity. We've got limited resources. Economists are always emphasizing opportunity cost. If we do this, we can't do that. So economists are always emphasizing sacrifice. And, well, while we're all aware of it, maybe we don't want that to be pushed in our face all the time. But I should stress that while it's true that economics does emphasize opportunity cost, the benefits we forego if we take an alternative course of action, while that's true, it's really important to emphasize that health economics is nothing to do with saving money. It's not at all anything to do with saving money. What health economics is concerned with is improving the quality of people's lives. Now that's going to take money, and the money you spend improving the quality of people's lives is taking away from somewhere else. But we're not, in health economics, concerned with saving money. Quite the reverse, we want to spend money to get benefit. But the key thing is, when you spend more money to get more benefit, you want to be sure you are getting more benefit and you're not losing more elsewhere than you're gaining. That's the key thing. You always want to, if you're going to do something new that brings benefit, that's great. Just be sure you're not losing more elsewhere. So how might health economics improve health and healthcare? Well, I think there's one main way in which health economics can help, and that's in understanding behaviour. Now, it might be the behaviour of consumers, as I say, for example, consumers, their utilisation of health services, or it might be their consumption of things like tobacco, or it could be their consumption of gym memberships, things like that. Their consumption of cycle trips, beneficial things. I was walking along the river this morning and I was struck by how many cyclists there were and pedestrians. And well, that behaviour, that decision to cycle or to walk, not to take the bus, not to drive a car, well, that is just a standard economic decision with lots of factors influencing it. Level of income, how much time you have available, what the alternative opportunities are in terms of public transport, private transport. But these sorts of things are all susceptible to traditional economic analysis. And so, health affecting behaviour, just like any other decision that we make, in principle, can be subjected to economic analysis. It's not just the behaviour, however, of consumers, or sometimes call them patients. It's also the behaviour of healthcare providers, those people who are supplying the healthcare. So one big area of health economics has been to look at financial incentives for different providers, particularly doctors, and to what extent medical doctors respond to financial incentives. Now that's fascinated economists because there's a little bit of an idea out there that medicine's a vocation. And while I can see it can be to some extent, that doesn't mean these individuals who've chosen, some of you who've chosen medicine, it doesn't mean that you aren't sensitive to different sorts of incentives, for example, financial incentives. Your behaviour may still be influenced by such things as money. We'll have an example of that in a minute. It's not just individual providers that respond to incentives, organisations also respond to incentives. And there's different, for example, there's different ways that we can reward hospitals for the care they provide. I'm woefully ignorant about how it's done in Japan. I don't know, you might have a sort of DRG system, a lot of the world does. But, well, if you pay hospitals that way rather than some other way, you get different behaviour. And studying these different behaviours is an interesting part of health economics. Now, does anyone know what this is? Maybe you're a little bit too distant. It's a man's body, yes. Most recognisable, I think, is that's part of the nipple in English. I think there's a belly button lurking here. Now, I saw this. It's not a selfie, by the way. I saw this on a bus shelter in London. It was part of an advert. And save the male, well, it's a sort of play on words. In countries other than Japan and Norway, we have some sort of emotional attachment for some reason to whales. And so Save the Whale is a sort of campaign. And so this campaign wasn't anything about marine mammals. This is Save the Male, and it was a campaign to highlight men's mental health, because young men and middle-aged men in particular are subject to quite a lot of mental health problems which they frequently don't seek help for, and they feel less able, shall we say, than, for example, their female counterparts, less able to when we recognise there is a problem and to seek help. And so this was trying to raise awareness about men's mental health. I include it though, however, because what it makes me more think about is not the mental health of men, but obesity, because that looks quite an impressive, yes. And so I just wanted to introduce obesity. And this is going to be an example of behaviour and how economics might tell you a bit about, give you some insights into human behaviour. And, well, that's the key message is this. Technology is fattening. Now, Japan is not the country probably to come and talk about obesity. I've noticed some people in this, they probably didn't come from Japan. I've noticed some people in the street who look on the larger side, but most people in Japan are very regular and actually to Western European appear not quite malnourished, but healthy, shall we say. But I guess even in Japan, probably obesity is an increasing problem. Nothing like the scale of problem it is in countries like England or United States or Mexico, but an increasing problem. Now, there's huge popularity in most of the world for all sorts of diets and things like that. You know, these ones where you eat 3 days and don't eat for 2 days. I'm not sure it's 2 days in a row, but you know, you have sequences of eating days, not eating days. You have these diets where you don't eat any meat or something, or these diets where you only eat meat, you don't have carbohydrates, etc. You've got all sorts of different diets. And then people do engage in these diets and almost always fail. If they make any progress, it all disappears. And this is true not just in our informal approach towards dieting. If you have a healthcare program where you're counselling individuals about diet and you're trying to help them control their intake and make progress, time and time again, yes, they'll lose weight and the BMI will start coming down, but over time it goes back up. They sort of rebound. And you can't help feeling, oh, it's sort of lack of willpower. You know, is there any need, you know, to have that extra bowl of, I don't know, ramen or something? Well, the ramen's not very fattening, is it? So that's not a good example. We love something in England called chips or fried potatoes. Fried potatoes. I know the rest of the world thinks of chips as what we call crisps. It's complicated, but chips are to us seen as very attractive. Potatoes deep fried, and we love these things. And people have this inner tussle, or cakes, or biscuits, or chocolate, and there's or ice cream, and they sort of, oh, I mustn't have that, I mustn't have that, and then they give in and they have it and they feel bad about themselves. Well, I bring you good news. It's not poor willpower that's making us fat. It's technology. We are not bad people. Again, the we is not, it's all these other people that who are a bit even higher BMI than I am. It's technology, and let me explain this to you. Technology has altered the relative prices of consuming calories and expending calories. So for example, if we think of consuming calories, that's eating, over the last 250 years, agricultural innovation has lowered the price of food. So the sacrifices we have to make in terms of, say, working time, etc., in order to get food have gone right down. So if you like, the price per calorie is going down and down, largely as a result of agricultural innovation. And of course, one of the lessons in economics is if the price of something goes down, the demand will go up. Not only that, technological innovation has changed the nature of work. When work was hard physically, when it was strenuous, workers were essentially being paid to exercise. They wouldn't see it that way. The person paying them wasn't saying, I'm paying you to exercise. The person doing the hard work didn't think, oh, this is good, I'm being paid to exercise. But that's what was happening. The nature of work, physical labour, was that you were being paid and you were getting exercise. Now, that doesn't happen very much. We sit largely at a desk in front of a computer screen for hours on end, and what's getting exercise is the sort of right hand or left, I never learnt to type with both hands. That's getting exercise. So now, if I want exercise, I've got to pay for the exercise. I've got to find the time, pay the gym membership, or buy the bicycle, get out on the road. I've got to do that. Whereas in the past, a lot of jobs involved physical labour, and so you got the exercise as a byproduct, shall we say. It's also the case that technological change has reduced the time costs of food preparation. Now, I think it's a bit a man talking to a predominantly female audience, saying how it's reduced the time costs of food preparation. It might sound a little bit funny because of sex roles in food preparation. Most men haven't had to suffer the burden of food preparation. But if you go over time, if you go back 100 years and then compare the technology available to man or woman in order to prepare food, it's been completely transformed. Think, for example, of things like food processors or food mixers. I'm sure you all have at some point, tried to whip cream just using a fork and your wrist action. Now, after about 10 minutes, the wrist's getting quite tired, and the cream is just beginning to sort of show little peaks. Well, technology, of course, you just go and you've done it instantly. Similarly, think of microwaves and so on. Think of deep freezers. So we can now produce large quantities of food and freeze what we don't eat just now. All of these things, just refrigerators, keeping food fresh for longer. This has all reduced the time costs of food preparation. And so it's another technological pressure making it easier and easier for us, the cost in terms of time or money, to consume food, consume calories, is going down and down and down. So as economically rational individuals, we're responding to this incentive, and we're eating more and we're getting fat. But it's not lack of willpower. It's not that we're bad people. Technology's to blame. And a little bit of lack of willpower. Let's not exonerate us too much. That was consumer behaviour. Just an example here of provider behaviour that can be studied. Now, this is a topic that's really attracted health economists. Something called supplier-induced demand. Let me say a bit about this. In economics, we're very used to thinking of demand as being based on an individual's preferences, the different value they put on different outcomes, their income, the relative prices of different goods, and these sorts of factors. And so we very much think of the individual as the demander. But in areas such as healthcare, while the individual does demand healthcare, that demand is frequently at least mediated through the doctor. And this is because of what we call the jargon, an asymmetry of information. Doctors have a lot of knowledge about how the body works, how it will respond to different treatments, what symptoms might be suggestive of what conditions. Patients have some knowledge, but much less knowledge about how their body works, about what opportunities there are for different treatments, what the prospects are of responding to different treatments. And so consequently, in the healthcare sector, we frequently, as patients, essentially give the decision making over to the doctor. There'll still be dialogue usually, one hopes, and discussion, but we stop being the demander, and at the very least it's a joint decision, shall we say, at the very least. And this has given rise to the possibility of supplier-induced demand, the doctor being the supplier. And so it might be that sometimes the demand for healthcare is not coming essentially from the patient, but is coming from the doctor. And so for a formal definition of supplier-induced demand, it's demand in excess of what would be chosen if the patient had the same information available as the doctor, but the patient still has their own preferences. So if the patient has the information, all that technical information and experience, it's not just information, if the patient has that knowledge that the doctor has, what would they demand? And if the demand is greater than that, if what the doctor's choosing for the patient is greater than that, that would be described as supplier-induced demand. And so this is possibly arising because in healthcare we have this asymmetry of information. Doctors are more knowledgeable than the patients. And to help us with our decisions, we go to the doctor, he or she then helps us. But one consequence might be that some of the decisions the doctor makes are influenced they aren't the decisions we would have made, they're decisions they are making. Now, this isn't restricted to healthcare. There's many situations of potential information asymmetry. Think of, have we anybody has a motor vehicle? Probably the wrong age segment of the population to have motor vehicles. But if you have a car or a motorbike, how knowledgeable are you about how that engine works? And if it makes a funny noise, do you know what's wrong with it? Do you know when it's making a funny noise, even? Or about house building? You've got a hole in your roof, maybe. It's leaking. So you can get up on the ladder, have a good look, diagnose the problem, decide what needs to be done? No. You typically put yourself in the hands of the builder. You put yourself in the hands of the car mechanic. Or a more exotic example, wine waiters. Have we any real sake experts here? I'm sure one or two, but you go to a restaurant and you might sometimes think, oh, it's a special, I really like something special today. I'll ask the wine waiter or whatever for advice. Or if you like modular organisers, I like this one. Some courses are optional, and you could go to the person who runs the course and say, do you think this course I should attend this course? Yes or no? Now, all of these situations have the same characteristic. The doctor, patient, car mechanic, motorist, house builder, resident, wine waiter, customer, module organizer, student. They're all characterized with this asymmetry of information. And so they all have a potential for supplier inducement, for a decision being made that's different from the one that, well, what we call I don't want too much jargon, the principal would have chosen if they had the same information. There's a couple of old examples here, but I like them. This was a study done a long time ago now, 20 years, goodness. Quite worrying how time passes. Caesarean sections. Now, you may or may not be aware that around the world, most countries, the rate of caesarean section is really quite high, and much higher than, for example, WHO would argue is necessary on medical grounds. Now this was a study done, so it's historical, but it looked at the United States, and between 1970 and 1982 there was quite a fall in US fertility. Probably not just in the US, but a 13.5% fall in fertility. And so what these authors tried to discover was whether or not this fall in fertility, and therefore consequent potential loss of income to obstetricians and gynecologists, whether this had any effect on their behaviour. And so, in particular, they were hypothesizing that because of the fall of fertility, these medical professionals might induce demand for caesarean sections, because caesarean sections, I guess in all countries, but certainly in the US, pay better than vaginal deliveries. Now, they were able to examine this because the timing and the extent of the fall in fertility in the United States varied across states. So some states, fertility started falling earlier than other states. Some states it fell a long way, some states it fell less far, the fertility. And so given this variability across 50 states over time in the decline in fertility, they could then try and associate that with what was happening to C-sections as a proportion of deliveries. And they found a strong correlation between the decline in fertility and the increase in caesarean section rates. Now, of course, this could be coincidental. But because fertility was dropping at different times, at different rates in different states, if there's another explanation, this was also having a differential effect, starting at different times, going at different states, speeds in different states. So there's a suspicion that it's not just chance. And the quantitative relationship is not vast, but a 10% drop in fertility was associated with a 0.6% increase in caesarean sections. Another example, this is again in the US, thoracic surgery. Now, there's a big federal healthcare program, Medicare, which is for the elderly. I think currently still defined as over 65s, although whether that's due for a reconsideration, I don't know. But Medicare is a federal, essentially, insurance program to cover the costs of a lot of the care of the elderly. And from time to time, they change the fees that they're willing to pay. And at one point, there was a reform of Medicare fees, which would have led to a 26% drop in the income of thoracic surgeons if they'd continued doing the same volume of activity. So there was the existing fee structure, it was changed. If these surgeons continued to behave in exactly the same way, their income would have dropped 26%. And what they observed was an increase in activity by thoracic surgeons, which allowed them to recoup or get back 70% of the lost income. Now again, it may just be coincidence, but that's what they found. Now, yeah.
What kind of activity?
Thoracic surgery specifically, where's the thoracic? In here somewhere, isn't it?
So they do more surgery?
Do more surgery, I guess, or request them to come back more often. I don't know. Any thoracic surgeons in the room? Yes. Well, that's the implication. The implication is that prior to the change in fees, they were doing particular procedures at a particular rate. After the change in fees, they were doing more procedures. Now, there may be other explanations. That's a good question. I don't really know what thoracic surgeons do. I mean, are there lots of things that are quite sort of optional? You know, you could do them or not do them, I don't know. But that's the implication, and that the patients go along with this because the asymmetry of information, they trust the surgeon to make the right decision in their interests. Now, I'm not asserting this happens, and it happens everywhere. I'm just saying this possibility has been recognised, and I've given you 2 examples of studies which suggest some evidence that there may be supplier inducement. Whether or not the supplier inducement is quite likely to be related to how we pay healthcare providers. Both of these examples are examples of what's called fee for service. You do more procedures, you get more money. So in both these examples, that was what was happening. And fee for service as a method of payment of doctors or health professionals, it probably has the greatest incentive for supplier inducement, because there's a bit more of a direct link. More activity, more income. We can compare that with, say, a salary. If the healthcare professional is receiving a salary, they get the same salary whether or not they do 100 procedures or 80 procedures. Or, for example, capitation payment, where you get a payment per patient that you're responsible for. Now, with capitation payments, if anything, the incentive's going in another direction. Do less for them, because that way you can have more patients. And so health economists have been quite interested in this area. Now, let me emphasize, we're not saying that doctors are bad people. We're just saying they're normal. They're human beings. And because they're human beings, actually it's not just human beings, pigeons respond to incentives as well. I mean, there's all sorts of experimental things you can do with pigeons or rats and mice. But let's just think about human beings. People respond to incentives. And I'm not saying that's the only thing that's driving their behaviour, just saying it's one of the factors. And so that's one of the areas that health economics likes to look into. And it's been a particular area for health economists because, as I say, it's just different from the normal model. When we think of demand normally, we think of, we've even got an expression for it, consumer sovereignty. Consumer sovereignty. The consumer is sovereign. They are king or queen. They decide. And that's how we usually think of as demand. But clearly in healthcare, and maybe in restaurants and motor garages and building construction, there may be other people involved in that decision. Now, I don't know if that's coming out very clearly, but this was a big advert I saw in Mexico City. I was lucky enough to be in Mexico City on sabbatical for 6 months. And I was just walking along and I saw this really big billboard, massive. You know. And as a health economist, I was immediately taken by it. I took the picture. Chocolate or boys? Now, there's differences of opinion on this picture. Some people could argue it's empowering of women. It's very much saying women have the choice. They can choose. Equally, I can see how you could see it another way and say, well, this is not actually very empowering of women. For a start, this assumption that it's chocolate or boys, that somehow if you go for the chocolate, your skin will be such and your body will be such that you'll never find a boy. It's also in our modern age, why chocolate or boys? Why not chocolate or girls? I mean, so you can interpret this picture different ways. I'm using it just in the sense that choice. We have choices. I'm not saying it's always chocolate or boys, it's the choice. To be honest, I don't really like boys or chocolate. But anyway, that's my problem, not anybody else's. So yeah, choice. That's the other area, informing choices, where health economics has a bit of a role to play. Now, there's lots of choices. It might be allocating resources across different healthcare programs. For example, we've got excellent evidence that oral rehydration salts reduce diarrheal disease in children. Indeed, a kind of, makes it sound like this lecture is sponsored, product placement. A can of Coca-Cola can actually be really quite good as well, but never mind that. We've got excellent evidence that vaccines against Hib work, very effective. We've also got excellent evidence that combination therapy for treating malaria works really well. But of course, we can't do everything. And we have to choose which programs we invest in. Now, of course, in a country like England or Japan, it's a little bit less pressing. We can do a lot of things because we're very wealthy countries. But in the larger part of the world, these are really tough healthcare choices. I emphasize all these programs work, there's no doubt about it. But which ones should we invest in? Well, economics can help you with that decision. And it helps you with that decision, and I'll clarify this next week, but it helps you with that decision by giving you tools by which you can assess the relative costs of different activities and the likely benefits. And once you've got that information side by side, it gets a little bit easier to make the choices as to what we're going to invest in. Or it might be choosing between treatments. So for example, if you're treating metastatic prostate cancer, enzalutamide works pretty well, abiraterone, mitoxantrone, and there's still others that work. Now again, you could just say, well look, if they work, let's make them all available. And that, to date, has rather been the Japanese approach. I say to date because you are going through a sort of, I don't know if it's still called a pilot, but you're engaging in some use of health technology assessment. You're exploring the use of health technology assessment to inform some of these decisions. But for example, a country like England, we don't assume that we will provide all these treatments. We, case by case, I don't mean patient by patient, I mean drug by drug, we make a decision. What is the evidence for its effectiveness? What is the evidence regarding the resource use? Does this imply this represents a good use of resources? And sometimes that'll involve deciding no, not to provide a particular treatment. Or it might not be a choice of treatments, it might be, this is more of a public health example. Suppose you've decided you're going to have a screening program. I guess there's a national breast screening program in Japan, is there? I'd be surprised if there isn't. But having decided you're going to have a national program for screening for breast cancer, you've still got lots of decisions. What age range are you going to invite to the program? For example, lots of countries start at age 60. Some start at 55. Some have an upper age limit. Initially, when breast cancer screening was introduced in the United Kingdom, we had an upper age limit of 65, because it was thought that over 65, women wouldn't really be very interested in coming along for breast screening. That wasn't evidence-based at all. That was just I think that was sort of 60-year-old men making some sort of assumption. We've now got to increase the age limit up to 70. You've also got an issue of how often do you invite. In England, we routinely invite women every 3 years. Some countries, it's every 2 years. In the United States, they don't have a national program, but the professional organization's recommendation is annual screening. We might be back to fee-for-service again, influencing that decision. You've got, is it 2-view or single view? You've got the mammogram, is it going to be interpreted by, well, a radiographer or a radiologist? Say it's a radiologist. Are you going to have just one person look at each mammogram, or are you going to have a second person look at each one? Now, all of these choices are economic decisions to a large extent, because they all have the characteristic that by changing the age range, changing the screening interval, going for single view or 2-view, going for single or double reading, they all can let you improve the effectiveness of the screening. You can detect more cancer. But they all will involve more resources. So is it a good idea? You've decided you want a screening program. Sorry, I'm just adjusting my step counter. It is product placement. These Fitbits, they've got a life of their own. They sort of spring themselves free from your wrist every now and then. Does anybody else have a Fitbit? No? You're all too healthy. My theory is it's unhealthy people have Fitbits because they need something to remind them to walk. Yeah, so all of these interventions, they all got this characteristic that you could always do a bit more, get more effect, in this case detect more breast cancer, but you'll then take more resources to do that. And so these are all, to some extent, economic decisions. Now, I don't by that mean they're just decisions for economists to take. I don't mean that at all. But they are fundamentally economic decisions. They're decisions to do more of one thing in order to get certain benefits. And the implication, you're doing less of something else. And that's what economics is partly about. Right, how are we doing for time? Now this says 3:36, so I have to either take away 4 or add 8. All right, good. Thank you. Yeah, you might say, why did he not adjust his watch to... It's all to do with... it's too complicated, but it's all to do with the steps, you see. You're trying to do so many steps in 24 hours, and it doesn't deal with time zone changes very well. Because it's a lot. I found with travel, it's a lot easier to leave this on currently British summertime, and yes. Anyway, that's okay. So I'll give you an example of this. So I'm going to go into more detail next week about hepatitis C because it's a particularly interesting one. But I guess most of you will know this, but maybe not all of you. Hepatitis C virus, it's a slowly, for most people, progressive disease of the liver. Again, the effects range, for many people, can be asymptomatic for a long time, or you could have quite mild disease, and that's 80% of those who are HCV positive are in that category, asymptomatic or mild disease. But at the more extreme level, you can get liver failure and also primary liver cancer. There's lots of different genotypes, 6 at least, and many subgroups in between. And the genotype pattern varies across countries. So for example, in England, those people who are HCV positive are generally GT1, genotype 1 or 3. And the other groups are not very common. I'm not sure what it is in Japan, but I know it's different. Part of me wants to say you've got more genotype 2. Any experts? No. Okay. That's quite relevant because to some extent different treatments work better, well, some treatments only work in certain genotypes, and other treatments, while they might work across genotypes, they may not work equally well across all genotypes. Now this area came to prominence really about five years ago, and it's because suddenly a new treatment came along that was much more effective than the existing treatments, and it was easier to tolerate. The evidence suggested not only was it more effective, better chance of clearing the virus, but also few or hardly any side effects of treatment, or sorry, adverse effects of treatment. And it was just a tablet per day, and 1 tablet per day just sounds just so easy. Also possibly for 12 weeks, although in some cases it's necessary to go for treatment for 24 weeks. Well, that compared with the existing treatments, which typically were for, well, a lot of the traditional treatments were for 48 weeks and were much harder to tolerate and did have higher rate of adverse effects. And so this just changed things, changed the landscape of treatment abruptly, and it's great news. When it was launched, its price in the United States was $1,000 per tablet. Now that's quite a lot of money. UK price was a bit cheaper, £400, but still that's quite a lot of money. Now, that's quite a challenge for a health system. You could argue they should have seen this coming, they should have planned better, but that's hindsight. And so all around the world, country after country, faced a major challenge. This was a condition which was hard to treat. The existing treatments were, well, if you could put up with the treatment and see it to the end of your 48 weeks, existing treatments were probably clearing the virus in 45 to 50% of cases. Slightly newer treatments had come along and they'd got that rate up maybe to 55, maybe approaching 60%. This comes along and suddenly it's a treatment that virtually anybody could tolerate, and clearance rates 90%, 95%. Indeed, more recent evidence, some of the studies suggesting almost 100% clearance of the virus. Now, it used to be the case in many countries that we almost didn't, well, it wasn't that we didn't treat HCV, but we didn't try very hard. Because, particularly in a lot of countries, the patient group that were suffering mainly were intravenous drug users. They're not the only group, but they were quite a large group. And these individuals, this is a terrible generalization, they have fairly disorganized lives, and so sticking to a tight treatment regimen for 48 weeks is just beyond many of them. And so for that reason, particularly in England, we weren't treating very many patients with HCV. I mean, we were treating some, but there had to be patients where the clinician felt, yes, they could stick with this. There's a chance they can follow the treatment. I guess in Japan, a little bit different. My understanding is most of your HCV comes from a vaccination campaign back in time when there was a certain amount of reuse of needles, innocent reuse of needles, just there wasn't a recognition that you might actually be spreading disease. And so it's not quite the same group of patients in Japan, although also your intravenous drug users will similarly have high rates of HCV, but this is the sort of general population would also be affected. And so to give you a sort of idea of what economics can offer, in England, there's an organisation, NICE, National Institute for Health and Care Excellence. Sorry, I shouldn't move around too much. I keep forgetting. I was just checking he was still awake. Yeah. And yeah, NICE make decisions about new treatments for the NHS. And if NICE make a positive recommendation, the NHS must make the new treatment available. If NICE don't recommend, NHS can provide a drug, but they don't usually because they haven't got the resources. And so a positive recommendation from NICE is very important. And so what NICE looked at, it's sofosbuvir, that's the name of the drug, and we looked across different genotypes. So there's, remember, genotype 1 and 3 are the main ones in England, certain amount of genotype 2, 4, 5 and 6, not very many. Another distinction here is, are you naive to treatment or have you experienced treatment already? Experienced and probably failed on treatment, presumably. Another distinction is also, are you interferon eligible or interferon unsuitable? Interferon at the time, pegylated interferon, was the main standard treatment. And another distinction, how far had your liver disease progressed? Was there any sign of cirrhosis yet or not? As the disease progresses, you move, if you continue to progress, you develop cirrhosis of the liver. And so we were able to distinguish all these different categories, and these are the recommendations we came up with. Now, green, this is green for go, that's recommended. Red for don't do it. And let's have a look at this. So if we look at the, I won't go through them one by one, but just get a flavour of it. So genotype 1 was a large group in England. If you were naive to treatment, the calculation was that compared to traditional treatment with pegylated interferon ribavirin, sofosbuvir, adding that in as a treatment, could produce additional quality adjusted life years at the cost of 15,000. So that 15,000 means if we introduce sofosbuvir for this patient group, we are going to gain additional years of life, but the idea of a quality adjusted year of life is trying to take into account the health state the patients are spending time in. So you might think of it as a year of healthy life, if that helps. So you could gain a year of healthy life for £15,000 on average across patients in this group. On the other hand, if they were unsuitable for interferon, introducing the treatment produced a gain in QALYs, but at £49,000 per QALY. And so a judgment is being made here that 15,000 is a price worth paying, £49,000 per year of healthy life is not a good one to pay for. We didn't have any data on treatment experienced GT1 patients who were interferon unsuitable, but given that that figure was 49,000, we anticipated it would also be quite high, and so also said no to that group. Moving on, for example, just GT3, this other big group, at least in England. Again, the treatment naive ones, it looked as if across all the patient group, so this is all the GT3 naive to treatment, if you're interferon eligible, the cost per QALY would be 21,000. And again, that was thought in the case of patients who had cirrhosis, it would probably be a bit lower, but if you had no cirrhosis, probably a bit higher. On average, 21,000. The difference here between cirrhosis and no cirrhosis is if you've no cirrhosis, you're sort of earlier in the pathway, and there's going to be a longer period of time before you develop the more serious problems. If you already have cirrhosis, you're much closer to getting the serious problems, the liver failure or the liver cancer. And so decision here was, yes, we could recommend it, but to those who are later on in the pathway, those with cirrhosis. And at the time, stress this is back then, a few years, if you were unfortunate enough to be GT4, 5 or 6, at that stage, there wasn't enough evidence really supporting the use of the treatment. And so you get this sort of pattern of results. You get evidence on the likely benefits, the likely costs, and you're able, if you so wish, to say, all right, these groups will get the new drug. These other groups, it doesn't seem to be good enough value. Now, I stress that it's not economists deciding that. It's economists and statisticians and others interpreting evidence, developing an economic model, producing these results. The decision is by a much more broader based group as to whether to go with that. Just another example. Trying to bring out the idea of opportunity cost here. This is from a quite well-known health economist, Nancy Devlin, and when she was at City University, she used to use these lectures, and I borrowed this slide. When I say borrowed, well, it's borrowed. She borrows mine, I borrow hers. It's sort of actually, it's a bit of social capital at work, perhaps. And when she did this calculation, IVF, in vitro fertilization, so it's assisting women with their, well, assisting couples with their, improving the chance of pregnancy. So for each course of IVF, you could have had 1/3 of a cochlear implant sort of in the ear. Now obviously you don't have thirds of implants. For 3 courses IVF, you could have had 1 cochlear implant. Or back then, it looks as if you could have 1 heart bypass operation. Quite a simple bypass graft, I think, at that cost. Or you could have 11 cataract removals. We could have 150 MMR, measles, mumps, rubella. This is just trying to highlight that whenever you do one thing, you're giving us something else up. Or, according to her calculation, 1/1000th of a Challenger 2 military tank. Now I'm surprised. I'd have thought you'd be giving up more like a 10,000th of a Challenger 2 military tank. But anyway, that was her calculation. The point she's trying to bring out here is, you could look at it purely within a health context, if you like, and look at the opportunity cost in terms of health. But of course, your decision could be to put more resources into the healthcare sector and you take it out of some other sector. Now, most people are quite willing to have fewer tanks. I'm not going to engage in Japanese politics because I don't know anything about it. And I do know that you, as a country, have a different attitude towards military than some other countries. But even in England, while we have quite a large army, most people are very willing at the idea. They think, oh, if I give up 1/1000th of a tank and I can get 150 MMR vaccinations, definitely let's do it. But governments do think it's important to maintain an army, etc. And so it's an opportunity cost still. Right. Now, I'm not going to go through this in any detail, but some of you may be aware of a medical journal called The Lancet. It likes to see itself as a sort of top medical journal. It's probably not quite as top like New England Journal of Medicine, but it's a very prominent journal. Ian Roberts, who was here earlier this month, some of you may have been along, he would always strive to publish there if he can. The editor is this guy called Richard Horton, and he's really into tweeting. And in blue, it's a little bit hard for you to read, a bit far out, but far away from you. But economics, second only to management, may just be the biggest fraud ever perpetrated on the world. It's quite tough criticism. And he then gave a series of tweets, and it added up in the end to about 10 of them. Well, I don't know his state of mind at the time or whatever, but anyway, I won't go through them all, but he's very critical of economics. I'll take the first one. The promise economics offers is seductive. How to allocate scarce resources, I've just been claiming this, in society. It's a false promise. It's almost Trumpian or Trumpesque, isn't it? Just state something, it's wrong, and it suddenly becomes fact. What ones do I particularly like? Number 5, economists see health as an economic good. It is an opportunity cost, I've been telling you this, with zero intrinsic value. Now this is just so wrong. Where do I start in explaining it? The whole point is health has value. We want more health. Mike Oldfield, I think, Tubular Bells, 1972, 3, was it? Tubular Bells?
I have no idea.
Oh. All right, it's quite a famous bit of music, Tubular Bells. I've just not, 1970 something. Okay, I'm sorry. Yeah, health has value. That makes it an economic good. It's not an economic bad, it's a good. We want it, we want more of it. To get more of it, we do incur opportunity costs. We have to give up something else. We can't just sort of wish it, say, oh, look, we really value health, let's have more health. We've got to take action to get that, and the actions will have consequences elsewhere. Now, there is an idea that, oh, the health service could always just be a bit more efficient. You know, people are just not doing things very well. Now, that idea has been around for decades, and to some extent it's true. You can identify things, areas of inefficiency. But year after year, healthcare professionals have been under huge pressure in most countries to be more efficient. And really, I think they're beginning to run out of things they can do to be more efficient. If you want more health, you're going to have to spend more money. And if you're going to spend more money, you're giving up something elsewhere. Anyway, at that point, I've got a couple more slides, but I'll use them to kick off the afternoon session. Okay, so we reconvene in 1 hour, I believe. Yeah?
Is it okay to ask some questions?
Oh, please do. Please.
In earlier lecture, I was personally surprised that you said health economics has nothing to do with saving money. That stuck in my mind
Mm-hmm.
because in my mind, health economics is nothing about cost cutting, but you said that's the opposite. So my question, the first one is how does cost effectiveness is talked about among health economists?
Right. Yes. Saving money is not what we're about. We're about getting more benefit from existing resources. Or, if you're going to bring in new resources, making sure the additional benefit you get from the new resources exceeds the benefit you've lost elsewhere where you've taken the resources from. Cost effectiveness, yes, we are very much interested in, because cost effectiveness puts the resource use together with the benefits. And you don't want to look at them in isolation. We don't want to just look at benefit, because we need to consider what it's costing us to produce the benefit.
Then my second question is, if you say cost effective, to whom?
Right. I guess what I've got in mind largely are publicly funded healthcare systems. So, not for the individual patient, but the patient as a tax-paying citizen. After all, it's not the government's money, it's our money. We give it to them, or they take it from us in the form of taxes. So it is our money. So it's the public perspective. And so what's cost effective for the public? Now, for the individual patient, I think I'm glad you raised that. That's a good point. What's good for the patient in terms of costs and effects could be quite different, because for the patient, in some systems, the cost they incur is very low and they get the benefit. So I'm thinking predominantly from the system point of view, and in particular a publicly funded system, where the greater body of patients, as citizens, we are providing the resource that the health service is then using. And the question is, how do we get more health benefit from that resource? Does that? I'm sure we can come back to this as a theme.
I think that's a big theme.
Yes. Okay, I think we might return to that in the afternoon session. Okay, thank you. Well, enjoy your lunch.